A previously healthy 16-month-old boy is brought to the physician because of decreased appetite, poor weight gain, intermittent diarrhea over the past 3 months. She has vomited once She has vomited one during this period. He has not had fever and his activity level has been normal. At the age of the 12 month, he was at 15 percentile length and the weight. He is now at 50 percentile length and 20 percentile for weight. Examination shows mild abdominal distension. Test of the stool positive for Giardia lamblia and negative for Cow's blood. Which of the following is the most likely mechanism of this patient's failure to thrive? Okay,
Okay. So the answer is malabsorption of fats and carbs. Giardia is a flagellated parasitic organism that causes giardiasis. Giardiasis is usually acquired through the ingestion of cysts in contaminated water, which then mature into trophozoites in the small bowel. Parasitic overgrowth of the small bowel leads to intestinal malabsorption of fats and carbs. Giardiasis presents with persistent diarrhea that is foul-smelling and fatty, as well as abdominal pain, bloating, cramping, and weight loss. Children and infants are more likely than adults to present with dehydration and may experience failure to thrive as a result of malnu- malnutrition, secondary to malabsorption. Diagnosis is made with stool culture, microscopy, or stool antigen testing. Light microscopy shows um, flagellated pear-shaped trophozoites with two large central nuclei and a medial axis style. Metronidazole is the first line of treatment. It is not B, inherited disaccharide deficiency. Underlies disaccharidase, underlies lactose intolerance. Infection with Giardia does not cause lactose intolerance. Okay.
next. 2 weeks after, sorry,
No, sorry, was reading the other one.
2 weeks
Yeah.
after a camping trip in New England, a 5-year-old boy develops 3 centimeter red circular lesion with a central lymphadenopathy, conjunctivitis, myalgia, and nausea. Antibodies to Proteus vulgaris was are negative. Which of the following is the most likely causal organism? Clear, clear center. And then 3 centimeter red circular clear center.
Clear center. Yes,
Clear.
cancer.
Conjunctivitis. Okay.
Okay. So is spirochete Lyme. Lyme disease is a thick. I didn't know Lyme had conjunctivitis. Lyme is a tick-borne disease caused by Spirochete borrelia burgdorferi, which is endemic to northeast U.S. and commonly transmitted by the Ixodes scapularis tick. It is in its early stage. It causes erythema migrans, which is expanding rash that may have a central ring-like feeling. Central. It can also be associated with a flu-like illness. Um, Lyme disease can be treated with amoxicillin. or doxycycline in the early stage, with amoxicillin preferred in pediatric patients. Doxycycline, which acts by preventing the attachment of amino acid tRNA to ribosomes, has adverse effects that include GI distress, photosensitivity, and in children, discoloration of teeth and inhibition of bone growth, which make it contraindicated in pregnancy and children under the age of 8 years old. Later stages of Lyme disease can be characterized by carditis, AV block, AV heart block, facial nerve palsy, which may be bilateral, migratory arthralgias, any left untreated, encephalopathy, chronic arthritis. Later stage of Lyme disease that affect the heart and central nervous system are treated with ceftriaxone. Other spirochetes include Leptospira treponema. Infection with Leptospira found in water contaminated with animal urine causes leptospirosis. That one I know. Characterized by flu-like symptoms, myalgia, jaundice, photophobia, conjunctiva injection. Treponema is the organism responsible for causing syphilis. No viral infection. Viral infections of the skin include varicella, zoster, and herpes simplex. Both present with vesicular rash rather than a single lesion with center clearing. Okay. Oh, sorry. Yeah. Borrelia. Center clearing. Okay.
Okay.
It's,
Yes.
it's called erythema. I want to see the central clearing. One moment.
Erythema chronica migrans. What you are looking for?
Mm-hmm. Migraine central clearing. What is the central clearing? Is it because it's different from? Because this is the one that I usually see.
Yes. Yes. True.
Like, this one doesn't really have a,
This is the bullseye rash, isn't it? Lyme
yeah.
disease.
But this one doesn't really have a center, or is it this that they call a central clearing?
It
Because the
is.
center doesn't have a
It
clearing.
is the center. The surrounding is not the center, isn't it?
But this is not clearing. Like this will be the clearing, like where it's like clear, it's not like red. Like this will be central clearing. Like this is different, but okay, okay. I guess just remember it's yeah,
Okay.
okay.
A 2-week-old girl is brought to the emergency department by her parents. Because of by her parents.
Are you still there?
Yes, I'm there.
Oh, okay.
Okay. A 2-week-old girl is brought to the emergency department by her parents because of 30 minutes history of her chest fluttering. 30 minutes ago, she vomited after breastfeeding. 30 minutes ago, she vomited after breastfeeding. She was born at 40 weeks of gestation following an uncomplicated delivery. She weighed 3.4 kg at birth. On arrival, she is awake, appears alert. Her temperature is 98.2 degree Fahrenheit. Pulse is too rapid to count. Pulse is too rapid to count. Respiration is 48 per minute. Blood pressure is 74 by 48. Examination, sorry, the extremities are pink and warm. Capillary refill is less than 2 seconds. The lungs are clear to auscultation. No murmurs are heard on a cardiac examination. ECG shows regular heart rate 240 per minute and the QRS duration 0.05 seconds and no discernible T wave. Application of the ice bag on the face for 5 seconds does not change the heart rate. Which of the following is the most appropriate next? Short.
What does she
Is
have?
it
A.
is it SVT?
Oh, I thought it was AFib. Never mind then.
Mm, regular heart rate,
What
ECG,
is it? Oh, regular, regular.
but heart rate is very high and QRS is very short. Normal QRS is probably 1 2 seconds,
Mm,
and there is no P wave, and there is no discernible P wave. That means no specific P wave. Heart rate is high. Looks like SVT. Hmm, SVT or VT?
oh, no.
I think that the SVT fits better.
Ready?
Yes.
Okay. It's administration of adenosine. This is SVT, so supraventricular tachycardia, commonly occurs in children and infants and is characterized by paroxysmal episodes of rapid neurocomplex tachycardia. SVT is often idiopathic and paroxysmal, but may occur secondary to accessory pathways in children with Wolff Parkinson White syndrome. Diagnosis is made by ECG, although some children may require cardiac monitoring in order to capture paroxysmal event. AV nodal blockade with adenosine is the first line treatment for narrow complex SVT. Adenosine is a pure analog that acts on the adenosine receptors, a G protein coupled receptor that signals through adenylate cyclase. In the AV node, binding of the adenosine A1 receptor leads to cellular hyperpolarization and reduced transmission of supraventricular action potential. If adenosine fails, synchronized cardioversion may be attempted. Children who are old enough may be trained to use vagal maneuvers in order to naturally induce AV node blockade. A similar vagal maneuver may be attempted by placing an ice back over the eyes and face to for approximately 30 seconds. It is not, digoxin is useful in the management of congestive heart failure. In AFib and flutter, it is not used for SVT. And then procainamide sodium channel blocker may be useful for achieving chemical cardioversion in AFib, but it is not first line for SVT. It's commonly used in arrhythmia management in Wolff Parkinson White syndrome, especially in cases of antidromic reentrant tachycardia. Verapamil, non-dihydropyridine calcium channel blocker, is useful for control of SVT, but it's not first-line agent for aborting the acute arrhythmia. It's also used for management of cluster headache. Catheter ablation, useful for the treatment of accessory pathways in Wolff Parkinson White. While Wolff Parkinson may be diagnosed in infancy, paroxysmal SVT is more common. Unsynchronized cardioversion delivers electrical shock at any point within the cardiac cycle. This method is reserved for pulseless vertical tachycardia and VFib in patients with SVT who failed treatment with adenosine. Synchronized cardioversion is preferred. Okay.
Next,
Mm-hmm.
an otherwise asymptomatic 4-week-old boy is brought to the physician because of increasing jaundice. Because of increasing jaundice for a week, he was born at term following a prolonged labor. One day after birth, he received phototherapy for jaundice, was discharged on the third day. He is exclusively breastfed. Examination shows no abnormality except for jaundice. A lab study showed hemoglobin concentration 12 milligram per deciliter, 12 gram per deciliter, and normal red cell morphology. Total serum bilirubin is 12, a direct bilirubin is 8. Which of the following is the underlying mechanism of this patient jaundice?
Hemoglobin is normal.
For baby, it is low, I think so.
Yeah.
But direct bilirubin is high. And Rubin Johnson on route. Indirect bilirubin is enzyme problem, isn't it?
Yeah,
Direct
we can.
direct is conjugated. Indirect is unconjugated, isn't it?
Indirect is uncle. Yeah. Increase serum bilirubin. Decrease serum bilirubin uptake. Decrease hepatic enzyme protein concentration. No. Decrease hepatic glucose transferase. Decrease bilirubin excretion between A and B. Decrease bilirubin. Oh no. Ready?
Yes.
Okay. Is decreased bilirubin excretion. Neonatal jaundice with a preponderance of conjugating bilirubin as indicated in this uh, yeah, is suggestive of biliary atresia. Biliary atresia is caused by abnormal underdevelopment of the extrahepatic vas biliary system. Affected infants are able to conjugate bilirubin normally in the liver, but are unable to excrete bile into the GIT. After infants present with worsening jaundice caused, affected infants present with worsening jaundice caused by conjugated bilirubin, along with pale stool, dark urine, poor weight gain, and untreated cases, cirrhosis, coagulopathy, portal hypertension. Conjugated bilirubin is water soluble and therefore does not cause kernicterus. Treatment includes surgical protoenterostomy to allow bile to be excreted or a liver transplant. It is not B, decreased hepatic glucose underlies the pathology of Gilbert and Crilley-Najjar syndrome. Both of these diseases are characterized by defective hepatic conjugation of bilirubin. Accumulation of unconjugated bilirubin is identified by increased serum concentration of indirect bilirubin. Decreased hepatic Y and C protein concentrations will interfere with hepatic bilirubin conjugation. These two proteins are involved in the cytosolic binding of bilirubin in hepatocyte and allow for the transport of bilirubin to the smooth muscle endoplasmic reticulum for metabolism processing. Okay.
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 a 4-year-old boy is hospitalized because of fever and shallow breathing and unresponsiveness for 3 hours. His temperature is 40 degrees Celsius, pulse 160 per minute, respiration 60 per minute, BP is 60 by 30. Examination show purpura over the lower extremity. He is intubated and mechanically ventilated. Blood culture show Neisseria meningitis 2 days after. Mm, 2 days later, X-ray chest shows bilateral patchy infiltrate. Which of the following is the most likely mechanism of this patient?
Ready?
X-ray.
Ready? Sorry.
Yeah, yes.
Is 35. Is increased vascular permeability. ARDS is a severe complication associated with numerous causes, including sepsis, aspiration, pneumonia, trauma, and shock. The syndrome results from the effect of cytokines on the pulmonary parenchyma following direct or indirect lung injury. This results in endothelial injury with increased vascular permeability, um, and exudative fluid extends into the alveolar space, resulting in diffuse alveolar damage and non-cardiogenic pulmonary edema. ARDS is characterized by respiratory failure, bilateral diffuse interstitial and airspace opacities from underlying diffuse alveolar damage, and non-cardiogenic pulmonary edema. Mechanical ventilation is often required in the management of ARDS as a result of hypoxemia and hypoventilation. Okay, next.
Yes, a two-year-old a two-year-old girl is brought to the physician by her mother for a well child examination. She is at 15 percentile for length and the weight, a grade 2 by 6 crescendo, decrescendo, systolic murmur with a musical qualities heard at the left lower sternal border with no radiation. Precordial activity and impulses are normal. There are no there are no previous notations of the murmur in the medical record. ECG shows no abnormality. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
So it's reassurance that this is a benign murmur. A still murmur is a benign asymptomatic murmur heard in children. It is systolic, musical, grade 1 to 2, best heard at the lower left sternum border, is typically louder when the patient is supine than when the patient is sitting. It most commonly results by adolescents. Pathologic murmur are more frequently heard in infants under 1 year of age, caused by abnormalities such as valve disorder or shunt lesions, whereas murmurs heard after 1 year of age are more frequently benign, although they can be caused by valve stenosis, regurgitation, or AFib or ASD. Pathologic murmur also present with related symptoms such as dyspnea, diaphoresis, or failure to drive. Further evaluation recommended for murmurs that are grade 3 or more. In intensity, diastolic, maximal intensity at the left upper sternum border, or systolic, have a harsh or blowing quality. It is also recommended for murmurs that are more intense in the upright position. As this patient has a benign still murmur, reassurance is appropriate. Next.
A 13-year-old boy is brought to the emergency department 2 hours after sudden onset headache, nausea, vomiting. 2 hours after sudden onset headache, nausea, vomiting during football practice. Although practice was held in the evening, the temperature outside was 85 degrees Fahrenheit and the humidity is 80%. The patient reports that he has been drinking water frequently during the practice. He has not eaten since breakfast. He has no serious illness, takes no medication. He is at 90% height, weight, and BMI on arrival. He is alert, responsive, and severely diaphoretic. Temperature is 102, pulse 100, blood pressure 110/77. Physical examination shows no abnormality, genital and pubic hair development tenor stage 3. Which of the following is most likely explanation of this patient's symptoms?
Ready?
Yes.
So is heat exhaustion. Athletes are at increased risk for heat exhaustion as a result of strenuous exercise in high temperatures and increased humidity. Other risk factors include lack of acclimatization, obesity, dehydration, And poor physical fitness. During exertion, the body is able to dissipate heat by increasing blood flow to the skin and producing sweat to facilitate evaporative cooling. However, when the ambient temperature is increased and humidity is high, these mechanisms are less effective at dissipating heat, resulting in heat exhaustion. Heat exhaustion is characterized by exercise intolerance, increased core body temperature, and the absence of neurologic disturbances, as the mental status, confusion, seizure. It's also associated with dehydration, tachycardia, lightheadedness, muscle cramps, and generalized weakness. Neurologic disturbances are associated with the more severe form of exertional heat illness referred to as heat stroke. Management of heat exhaustion involves removing the individual from the heat, removing excess clothing, initiating cooling measures such as immersion in cool water and evaporative cooling. It's not hypoglycemia can cause confusion, altered mental status, lightheadedness, syncope. The patient would be at risk for hypoglycemia as a result of exercising after not eating since breakfast. However, healthy individuals are typically able to maintain a stable serum glucose concentration because of hepatic glycogenolysis during periods of exercise and fasting. Hypoglycemia will not cause hyperthermia. Hyponatremic dehydration can occur in subacute or chronic severe vomiting and diarrhea as a result of loss of electrolytes, including sodium and water. Dehydration increases the action of ADH, leading to increased free water reabsorption in the collecting tube, and can further contribute to hyponatremia. Okay.
Next,
Okay.
a previously healthy 17-year-old girl is brought to the emergency department 40 minutes after being stabbed in the left side of her chest with a pair of scissors. En route, the hospital IV ringer selected was administered. IV ringer selected was administered. Administration of oxygen 3 liter per minute, 3 liter per minute via face mask has begun. On arrival, she has severe chest pain. She is agitated, diaphoretic, and is not oriented to person, place, or time. Her temperature is 37.2, pulse is 128, respiration is 32 per minute, palpable systolic blood pressure is 80 millimeter mercury. Examination shows jugular venous distension bilaterally. The trachea is deviated to the right, breath sound is decreased on the left, and hyperresonance to percussion. Which of the following is the most appropriate initial step? Okay.
Ready?
Yes.
Okay, so it's needle decompression. Tension pneumothorax can be a complication of penetrating thoracic trauma. It occurs when air is able to enter the pleural space but is prevented from exiting. Increasing amounts of trapped air in the pleural space compresses the lung parenchyma, creating an inability for the lung to expand and causing it to collapse. As the pneumothorax progresses and continues to increase in size, it can result in tracheal or mediastinal deviation away from the affected hemithorax. It can also result in compression of the pulmonary veins and superior vena cava. Okay, resulting decreasing venous return to the left and right atria, which manifests with hypotension, jugular venous distension, and obstructive shock. Tension pneumothorax characterized by absent breath sounds and hyperresonance to percussion caused by increased air in the interthoracic space, displacing normal lung parenchyma. In an unstable patient, air from tension pneumothorax should be evacuated by emergent needle decompression followed by tube thoracostomy. Okay, next.
After undergoing tonsillectomy, a 2-year-old boy developed seizure in the recovery room. During 45 minutes of operation, he received 1 liter 5% dextrose in water, measurement of which of the serum concentration most likely to mm, confirm the diagnosis.
Ready?
Yes.
This sodium. The patient is likely suffering from acute hyponatremia complicated by seizures after receiving hypotonic fluid for his procedure. Measurement of sodium concentration will confirm the diagnosis. Sodium is the most prevalent extracellular cation, and maintaining a normal serum concentration is essential for the proper functioning of tissue and movement of water um, between the intracellular and extracellular spaces. The arrangement of sodium concentration are mostly caused by imbalances in water content of the extracellular fluid as regulated by ADH, as opposed to actual changes in the total body's sodium content. Administration of hypotonic fluid, such as 5% dextrose in water, dilutes the serum, resulting in osmotic pressure that drives water molecules into the intracellular space. The primary acute symptoms are because of an acute cerebral edema, which can progress to altered status, gait disturbance, seizure, coma, death. Management requires a careful return of sodium to normal serum concentration. It's not creatinine, it's used as a marker for GFR. Increased serum creatinine concentration can indicate acute kidney injury, which can be a complication of surgery as a result of transient hypotension. Administration of IV fluids during procedures reduces the risk. Okay. Glucose is concentration are likely increase in this patient receiving dextrose. The decreased glucose concentration can present with altered mental status seizures. In the absence of insulin resistance, temporarily increased glucose concentration are unlikely to cause symptoms. Okay, next.
A 16-year-old girl is brought to the emergency department by police because of 5-hour history of hallucination, profuse sweating, and intermittent yelling and fleeing. He is striking out at those near him, requires leather restraints. His pulse is 110 per minute, respiration 20 per minute, BMI 150 by 80 millimeter of mercury. Physical examination shows pallor, diaphoresis, recent bruising. Mental status examination shows incoherent speech, episodic screaming, and agitation. He is disoriented to person, place, and time. The most appropriate next step in the management of administration of which of the following requires leather restraints? He's taking tarpin, like alcohol type of thing.
Really? I don't know. Therefore, I don't know what intoxication, but I know it cannot be opioid because everything is high. And it cannot be, so it's not, it won't be naloxone, I'm thinking. And it cannot, flumazenil is flumazenil. It's for what, benzos? So it cannot be benzo because, again, he wouldn't be like, everything is high. So he wouldn't, you know. So I'm just thinking it's probably like some sympathomimetic. I'm thinking. Ready?
Yes.
Okay. So it's lorazepam, it's PCP. Oh, yes. It's an illicit substance that acts on the CNS in a
Is
variety of
there
ways.
anything striking point present? in here?
No, here I don't think you needed to know exactly what things he's taking. You just needed to know like everything is high, so it cannot be opioid, so it's not naloxone, and it cannot be benzo, so it's not flumazenil. The the other answer, I think you can delete it. I don't know, 50%. I don't know. I don't know why you will give. Yeah, you can delete. So the only thing you have left is lorazepam, and you kind of say even for alcohol, you will give when the patient is agitated. I think you give a benzo to calm them down first. If the patient is,
Yes.
I don't remember. Yeah, but I think yeah. So yeah, that's kind of you didn't need to know exactly what he had taken. Okay.
Okay.
PCP is an illicit substance that acts on CNS in a variety of ways. It antagonizes NMDA receptors, leading to excitatory neurotransmitter release. Okay. Inhibits the uptake of dopamine, norepinephrine, and serotonin. It stimulates uh, alpha receptors. Acute PCP intoxication can lead to psychosis, bizarre behavior, agitation, aggression. That's the key. Rotatory nystagmus, and ataxia. Patients may be diaphoretic, tachycardic, hypertensive because of symptomatic effects. Chronic PCP use can lead to MDD, psychotic symptoms, memory loss, dysarthria. Control of psychomotor agitation is the first step in management of patients with PCP intoxication for the safety of the patient and the medical staff. Chemical sedation with benzo, such as intramuscular lorazepam or midazolam, can be administered to control symptoms. Once a patient is adequately sedated, further evaluation can be completed to assess for traumatic injuries or complication of PCP intoxication, including rhabdomyolysis, hyperthermia, hypertension, seizures, encephalopathy, and coma. Next.
Okay. Can you take
Mhm.
a 5 minute break?
Yes, we can.
Okay. I'm coming.
Okay. Yeah. Hear
Okay.
me?
Yes. Question 41. An asymptomatic 10-year-old boy is brought to the physician for a health maintenance examination. He has no history of serious illness, takes no medication. His parents both have essential hypertension and hyperlipidemia. He has an active lifestyle and plays several sports. He consumes a wide variety of food, including fruit, vegetables, drinks, and two or 2 to 3 glass of each whole milk and fruit juice daily. He is currently at 90 percentile height and above 97 percentile of weight, and BMI vital signs are within normal limit. The remainder of the examination shows no abnormality. Which of the following is the most appropriate dietary recommendation at this time?
Ready?
Ready? Okay.
It is decrease intake of milk and fruit juice. This 10-year-old boy displays signs concerning for obesity. BMI is like over 97 percentile. Pediatric obesity causes health consequences in nearly every organ system, including cardiovascular like hypertension, dyslipidemia, endocrine like diabetes, hyperandrogenism, early menarche, GI like non-alcoholic fatty liver disease, musculoskeletal like scurvy, pulmonary like obesity, hypoventilation syndrome, and OSA. This patient is at further increased risk given this family history of hypertension and dyslipidemia. The first step in weight management in this patient is to decrease his caloric intake. His dietary history discloses that he's drinking an excessive amount of high caloric beverage, including whole milk and fruit juice. While milk contains beneficial nutrients such as calcium and vitamin D, whole milk contains approximately 100 calories per 8-ounce serving. In contrast, fruit juice has little nutritional value and also contains approximately 100 calories per 8 serving. This simple dietary intervention is the most appropriate first step in management um, this patient weight.
Okay.
Okay, nice.
A previously healthy 4-year old a previously healthy 4-year-old boy is brought to the physician because of 1 week history of intermittent fever. During the past 3 days, he has had decreased activity and joint pain. Yesterday, he developed red rash on his chest. He attends daycare, he appears pale, and he is not in acute distress. His temperature is 101 degree Fahrenheit, pulse is 140 per minute, respiration 24 per minute. Examination show petechial rash over the chest, the conjunctiva are pale. Mm, there is diffuse adenopathy in the cervical chain. A grade 2 by 6 systolic murmur is heard, and the spleen is palpated 1 centimeter below the left costal margin. There is no swelling, redness of the joints. Lab studies show a hemoglobin concentration 6.4, leukocyte count is 50,000, and platelet count is 10,000. Which of for each patient with anemia, which of the following is the most likely diagnosis?
Mm, mm,
Why it is us?
between us and
In us, uh, there is never like look at the leukocyte count. In
leukocyte,
us, there is anemia, thrombocytopenia, and acute kidney injury. The anemia is right, thrombocytopenia is right.
no, there is
There
no
is no
acute.
acute kidney injury, but leukocyte count on us is normal.
Okay, so it's not us. Leukocyte count, leukocyte count, leukocyte count. So is it sickle cell?
This sky high leukocyte count, like sky high means very high leukocyte count, along with in here there is only diffuse adenopathy in the cervical region, but and
Is it
spleen is
region?
palpated also,
Spleen is palpated.
like hepatosplenomegaly, high leukocyte count, little baby.
Oh no.
Okay,
Okay.
let's see the answer.
Let's see. It's ALL. Oh, did not see that. Oh, okay. Got it, got it. Previously, no. ALL is the most likely cause of this patient's anemia and is likely the result of diffuse bone marrow infiltration by malignant blast cells with subsequent displacement of normal erythroid progenitor cells. The diagnosis of leukemia is supported by the presence of fever, petechial rash, diffuse retinopathy, splenomegaly, and leukocytosis. Evaluation of the peripheral blood smear will most likely show malignant circulating blasts of the lymphoid lineage. B lymphocyte malignancies are more common than T lymphocyte malignancies. An evaluation with flow cytometry is necessary to determine the specific type of malignancy, followed by mutational analysis. Treatment typically entails chemo, and many patients with ALL will enter remission. Um, bone marrow transplant can be curative in many cases, and it's not HUS, classically associated with infection for E. coli, that one. It often presents with children bloody diarrhea, anemia, microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. And I was also between sickle cell caused by mutation of the beta globin gene alleles that result in abnormal hemoglobin S, which polymerizes abnormally in hypoxia and causes sickling of erythrocytes. Nothing else. Okay, next.
A 7-year-old girl, JRA, juvenile rheumatoid arthritis, is brought to the physician because of 1 year history of progressive fatigue. She has had occasional fever, swelling, and pain of the knees during the past month. She appears ill. Her temperature is 102, pulse is 104 per minute, respiration is 20 per minute. Examination shows pale conjunctiva. The spleen is palpated 2 centimeter below the right costal margin. The right knee is warm. Erythromatous mildly swollen. Hemoglobin 9.5. MCV 75. Hemoglobin 9. MCV 75. Leukocyte count is 11,000. Platelet count is 40,000. For each patient with anemia, seen the diagnosis.
So reticulocyte count. Where is the reticulocyte count? Scenario. The platelet count. Scenario. But the responsive fatigue, using fever, pain of the knees, appears ill. Mm-mm. Anemia of chronic disease, hemolytic anemia, leukocyte hemolytic anemia, hereditary spherocytosis, lead poisoning, thalassemia, mm, anemia of chronic blah, blah, blah. Between why he has swelling blah blah blah. I guess this one. Ready?
Yes.
Okay. So it's anemia of chronic disease. This patient with GIA with fevers, fatigue, right knee effusion, splenomegaly most likely has anemia of chronic disease, ACD. ACD is found in many autoimmune infectious and malignant disease states. Chronic inflammation results in increased hepcidin production, which consequently leads to a decreased responsiveness of the bone marrow to erythropoietin and retention of iron within the reticuloendothelial system. This confluence of factors leads to a state of functional iron deficiency despite adequate iron store. Um, Patients present with either normocytic or microcytic anemia and reduced number of reticulocytes, indicating inadequate bone marrow response to anemia. Other lab findings include a normal, slightly high ferritin concentration with decreased serum iron concentration and total TIBC. So TIBC is also low. Okay. Want me to read another one?
No.
Maybe.
Okay. Next.
Okay.
A 14 a 14-year-old girl is brought to the physician because of lower abdominal cramps and intermittent pain in knees and hips for 6 weeks. The cramps are relieved. The cramps are relieved by bowel movements. During this period, she has she has 6 to 10 bloody bowel movement daily. Examination shows swollen, mildly tender right knee joint. Her hemoglobin is 14.5. Leukocyte count is 16,000. Platelet count is 79,000. Analysis analysis of the knee joint, straw color turbid fluid with the leukocyte count 2000. 40% segmented neutrophil. Which of the following is the most likely diagnosis? Mm,
Adenovirus cystitis.
okay.
One moment. Pseudomembranous enterocolitis. Okay, ready. It's ulcerative colitis. Ulcerative colitis, UC, is a type of IBD that results in inflammation and ulceration of the colonic mucosa and submucosa, typically beginning in the rectum and advancing proximally in a continuous distribution. Symptoms include chronic abdominal pain, weight loss, bloody diarrhea, abdominal bloating, and tenesmus. Imaging typically demonstrates loss of ulceral markings. Diagnosis of ulcerative colitis by colonoscopy and biopsy, which demonstrates characteristic crypt abscesses, potential complications of UC, fulminant colitis, toxic megacolon perforation. IBD can also be associated with intestinal manifestation, including uveitis, arthritis after stomatitis, and pyoderma gangrenosum. Treatment includes immunomodulators, biologics, and steroids. Although total colectomy is generally curative and will eliminate the patient risk for colorectal carcinoma. It's not E. Pseudomembranous colitis is caused by C. diff, which produces toxins that result in dysfunction of the brush border and a subsequent secretory diarrhea. C. diff infection are associated with the presence of pseudomembrane that appears as patchy regions of white mucosa on colonoscopy. C. diff infection is an opportunistic and often hospital-acquired infection that commonly occurs after the use of antibiotics, especially ampicillin and clindamycin. Okay, got it. Next.
A previously healthy 7-year-old boy is brought to the physician because of progressively worsening headache and difficulty walking over the past 6 weeks. Examination shows bilateral papilledema, right abducens palsy, and gait ataxia. Which of the following is the most likely diagnosis? Bilateral abducens.
Hmm, Dandy Walker. Meduloblastoma. Dandy Walker. Medulo. Headache. It's not acoustic. Between B and C, medulloblastoma, Dandy Walker, Dandy Walker. Uh, Probably the Dandy Walker. Next. Oh, sorry. Ready?
Yes.
Ready? Probably the Dandy Walker. Oh, medulloblastoma. Medulloblastoma are the most common malignant brain tumor in children. The peak incidence is like 5 to 9 years of age, and they are frequently located in the cerebellum. The position of a medulloblastoma in the cerebellum typically leads to occlusion of verticular drainage, which causes increased intracranial pressure. Those patients typically have headaches and nausea from increased intracranial pressure, as well as gait ataxia or incoordination caused by cerebral disruption. Makes sense. Physical exam will often demonstrate nystagmus, dysdiadochinesia, dysmetria, cranial nerve pulses, and papilledema. Diagnosis is made with MRI and biopsy, with the specimen for the later most commonly taken during the surgical resection. Lumbar punctures are also performed to evaluate for metastatic spread through the CSF and spinal leptomeninges. In addition to surgery, treatment includes radiation and chemo. Complication includes neurologic abnormalities such as developmental delay, hearing loss, and endocrine abnormalities. It's not acoustic neuroma is a benign tumor of the Schwann cells that arise from vestibulocochlear nerve. It presents with ipsilateral hearing loss and vertigo. Um, hearing loss, as well as ipsilateral dysmetria if compressing the cerebral peduncle. This patient does not have hearing loss. Dandy-Walker syndrome is a condition in which the cerebellar vermis and fourth ventricle are malformed, resulting in cystic enlargement of the fourth ventricle and posterior fossa with consequent hydrocephalus. It presents early in life with developmental delay, hydrocephalus and cerebellar or cranial nerve dysfunction. It will be less likely in this previously healthy 7-year-old. Okay.
Next.
Mhm.
A previously healthy 15-year-old boy is brought to the emergency department because of right scrotal pain and swelling for 3 hours. There is no history of trauma. She is sexually active 3 months ago and did not use condom. Examination showed tenderness and edema in the region of the right testicle. The cremasteric reflex is absent. Which of the following is the most likely cause? Cremasteric reflex is absent.
Tenderness and edema.
Is it torsion?
Sounds like it. Leukemic infiltration of the testis. Mm, Ready?
Yes.
Okay. So it's twisting of the spermatic cord. Testicular torsion occurs when the testicle rotates about itself within the scrotal sac. The resultant twisting of the spermatic cord, which contains the gonadal artery, pampiniform plexus, and gonadal vein, results in vascular congestion and potential cessation of venous and arterial flow to the testis. Patients typically present with acute severe testicular pain with diffuse tenderness and swelling. Patients may also exhibit nausea, vomiting, and lower abdominal pain. There is typically a negative cremasteric reflex with a high riding transverse line of the testicle. If not properly and expeditiously managed with surgical detortion and archaeopexy, testicular torsion can result in testicular infection as well as infertility. Let me see. Let me read C and D. Persistent patency of the processus vaginalis can lead to formation of hydrocele if filled by peritoneal fluid, and hematocele if complicated by blood accumulation. It also increases the risk of indirect inguinal hernia. Persistent patency of the urachus contributes to a persistent connection between the bladder and the umbilicus, urachus. Patients with patent urachus present with clear urine leaking from the umbilicus. It can also be asymptomatic or potentially complicated by infection. Okay, next.
A healthy 9-month-old girl is brought to the physician by her parents for a well child examination. Her parents are concerned that she is not gaining enough weight. She is breastfeeding 6 times daily. She is breastfeeding 6 times daily, taking small amount of baby food from a spoon. She is at 5th percentile weight, 25th percentile length, and a head circumference. Review of the growth chart shows that this growth pattern has been consistent since birth. Physical examination shows no abnormality. Which of the following is the most appropriate next step in a match?
Hmm, I don't know. Is it reassurance? Fifth percentile for weight. Ready?
Okay.
Okay. It's reassurance that this growth pattern is within normal limits. Growth charts show the percentile curves of body measurements such as head circumference, body weight, length for children. They are used to evaluate for normal growth, short stature, growth delay, failure to thrive, nutritional deficiencies, malabsorption, and endocrinopathy, and other disorders. Clinicians use the growth chart provided by the World Health Organization, which is an international standard for infant growth. For infants less than 2 years of age, infants are classified as low weight or short stature if they are less than the 2 percentile for weight and length. Low weight, okay. This patient is at the fifth percentile for weight, which, while low, is not yet of concern. In addition, her growth pattern has been consistent since birth. Further assessment to investigate growth or nutritional problems should be performed if infants are less than two than the second percentile, or if there are major changes in growth pattern. So for weight and length, increasing the caloric intake by adding more baby food will not be appropriate recommendation as the patient weight and length are within normal limits on the growth chart. This may be appropriate if the patient weight was less than 2 percentile and the reason for growth delay was inadequate caloric intake and is not supplementing breastfeeding with whole cow meal will be harmful to the infant. Early induction of whole cow milk prior to 1 year of age has been associated with type 1 diabetes, increased risk for developing cow milk allergy, constipation, and iron deficiency anemia. Okay, next.
Yes. An otherwise healthy 16-year-old girl is brought to the physician by her mother because of 6 months history of increasingly severe pain with menses. Her mother reports that during this time her daughter has missed 2 days of school during each menstrual period because of severe pelvic cramps associated with vomiting. Mens occur at regular 28 days of interval, lasts for 4 to 5 days. Her last menstrual period was 7 days ago. She currently takes acetaminophen, which provides minimum relief of her symptoms. She has had 3 lifetime sexual partners. They use condoms inconsistently. The patient is an honor roll student despite frequent absence from school. Physical examination shows no abnormality. Pelvic examination shows tender, normal-sized uterus and no masses. Which of the following is the most appropriate next step in the management?
We do the pregnancy, even if she has, she doesn't have any
Last
signs of
menstrual period is 7 days ago.
days ago, so probably not. Ready?
What do you want to do? Pelvic ultrasonography?
I'm thinking it's endometriosis or no. I don't know. But I was going to give NSAID, but she already taken acetaminophen. And then pregnancy test, I was going to do it, but she doesn't have any other signs of pregnancy. Even if she doesn't use condoms, so that. So maybe it's pregnancy. I don't know. But she
Okay.
has a normal status. Oh my God. Okay, so it's primary dysmenorrhea or painful menstruation. Is a common cause of cyclic pelvic pain in healthy females and occurs in the absence of secondary causes such as endometriosis, adenomyosis, cervical stenosis, or uterine fibroids. Symptoms often begin during adolescence and commonly interfere with quality of life and with essential activities such as school and work. Patients describe crampy lower abdominal or pelvic pain that begins several days prior to the onset of menses, which persists for several days along with fatigue, nausea, vomiting, presyncope symptoms, headache. Endometrial sloughing is accompanied by the production of prostaglandins, which stimulate painful uterine contractions. Um, Patients are typically treated with NSAID that inhibit COX enzyme, thereby limiting prostaglandin synthesis, and with oral OCPs. Pregnancy tests can be used to evaluate for pregnancy, particularly ectopic pregnancy in the setting of severe abdominal pain. However, this patient's most recent period was 7 days ago, making pregnancy unlikely. It's not pelvic ultrasound can be used to evaluate for structural abnormalities of the uterus and agnesa, such as fibroids or ovarian cysts that can cause recurrent abdominal pain. However, there was no evidence of structural abnormalities during the patient pelvic exam. Okay.
Next, a 9 month a 9 month old boy is brought to the physician. A, ni- a 9 month old boy is brought to the physician 2 months after parents noticed that he seemed to be ignored them. On questioning, they note that he does not appear to be startled by loud noise. Growth and development has been otherwise normal. He was born at term 28-year-old woman gravid to para 1. Her mother's blood group is ARH negative. His blood group is ARH positive. Mother's. Okay. Total bilirubin is 25 at the age of 2 days. Received phototherapy. He continued to be mildly jaundiced until 1 month. Serum studies show no abnormality. Examination to show no abnormality. Which of the following most likely prevented from these conditions?
Mm. Ready?
Yes.
Exchange transfusion. Kernicterus occurs as a result of deposition of unconjugated bilirubin in a newborn's brain, usually in the basal ganglia, the pons, and the cerebellum. It typically presents with poor feeding, lethargy, and seizures. If untreated, it can cause long-term neurologic abnormalities such as gaze palsies um, or sensorineural hearing loss. Okay. Unconjugated or the indirect bilirubin is circulating insoluble bilirubin that is largely bound to albumin. It has not yet undergone conjugation in the liver. Causes of increase in conjugated bilirubin include hemolysis, breast milk jaundice, Crigler-Najjar, Gilbert syndrome, physiologic jaundice. In newborn, causes also include maternal exposure to sulfonamide antibiotics, which displace bilirubin from albumin in the neonate, thereby increasing the free plasma concentration of unconjugated bilirubin. Kernicterus typically occurs when the bilirubin concentration exceeds 25 to 30, which is commonly caused by glucose 6 phosphatase dehydrogenase deficiency or Rh hemolytic disease of the New World, the latter of which was likely present in this patient given the discordant Rh status of him and the mom. These factors include prematurity, cephalohematoma, or significant bruising, poor breastfeeding, and East Asian ethnicity. Treatment to prevent severe unconjugated epibilirubinemia and subsequent kernicterus is phototherapy or exchange transfusion. Exchange transfusion are particularly useful in hyperbilirubinemia disposed by anti-RH antibodies as they allow removal of the antibodies as well as the bilirubin.
Okay.
Okay, next.
A 4-year-old boy had fatigue, decreased appetite, and a 2.3 kg weight loss over the past 2 months. He appears listless. His pulse is 80 per minute while supine and 105 per minute while standing. His blood pressure is 85 by 60 while supine, 75 by 45 while standing. Serum glucose is 465 milligram per deciliter. Urinalysis show 3 plus creatine, 4 plus glucose. 1 to 2 WBC. Which of the following is the most appropriate next step? Uh, is it
We give,
DK?
s- I don't know, but it's definitely something to do with glucose, with high glucose. I wonder, do you give saline or do you give insulin first?
I think that saline infusion should be the first thing
Okay,
in case of DK.
okay. So the answer is saline infusion, IV. A pediatric patient presenting with fatigue, decreased appetite, weight loss, hyperglycemia raises suspicion of type 1 diabetes. Type 1 diabetes can also be complicated by DKA, and patients can present with DKA as their initial manifestation. DKA can also result from increased insulin requirements during times of physiologic stress like infection or insulin non adherence. Decay occurs as a result of the accumulation of serum ketones such as beta hydroxybutyric acid, acetoacetic acid, and acetone in the setting of deficient insulin signaling. Dysregulated fatty acid degradation and ketone synthesis occurs because of the relative state of starvation created to the absent insulin um, signaling. Type 1 diabetes can also result in dehydration caused by hyperglycemia, glycosuria, and osmotic diuresis. This diuresis can result in dehydration, ketonuria, and orthostasis. Orthostatic vital signs are significant pulse increases greater than 20, systolic pressure decreases over 20, and diastolic pressure decreases over 10 with changes in position from supine to seated, from supine to standing. Systolic less than 20. Okay. Because of the patient osmotic diuresis, orthostatic hypotension, and dehydration, the first step requires the administration of saline IV for fluid resuscitation. It is not administration of insulin. Subcutaneous insulin can be helpful in this patient, although insulin should be administered IV for the management of decay once the patient is appropriately resuscitated with intravenous fluid. In a patient with signs of dehydration and orthostasis, IV fluids should be given um, first. And it's not A1C useful for diagnosis of long-term management of diabetes. It will be less helpful in the acute management of a new diagnosis of diabetes and decay. Okay, we are done.
Okay, we are done.
Okay, what do
Can
you want?
let's end for today.